Member Roundtable with the Center for Disease Control and Prevention. I would like to welcome our subcommittee members and thank Dr. Rochelle Walensky, Dr. Ann Schuchat, and Dr. Nancy Messonnier for joining us this morning. And welcome to everyone who's following the live stream of today's discussion. Before we begin, I would ask all members to keep themselves on mute until we reach the question and answer portion of today's discussion. Our format this morning will be to hear from the experts at CDC and then to open up the briefing for questions from members. I will note 1 year ago, it was February 10th, 2020, that this subcommittee held a member briefing with Dr. Messonnier, Dr. Fauci, and HHS Assistant Secretary for Preparedness and Response, Dr. Kadlec, just as our nation was in the early stage of the COVID outbreak. Here we are, 1 year later, holding this discussion remotely, as our daily lives have been significantly changed due to COVID, just as, I might add, Dr. Messonnier rightly forecasted. And Dr. Messonnier, welcome back. Your voice has been missed for many, many months. For the past year, we have simultaneously been struggling to combat a public health emergency and an economic one. Tragically, COVID-19 has taken the lives of over 500,000 Americans during that time. We must continue to do everything in our power to defeat this virus. Throughout the course of the past year, thousands of dedicated CDC career staff have worked tirelessly to confront this pandemic and continue to do so. I am grateful to each of them. I will just take a moment to introduce Dr. Rochelle Walensky, Dr. Ann Schuchat, and Dr. Nancy Messonnier. Dr. Walensky was sworn in as CDC Director on January 20th, just 1 month ago. And we are so pleased that she is a part of the White House team providing regular COVID response briefings. Prior to her current role, Dr. Walensky served as Chief of the Division of Infectious Diseases at Massachusetts General Hospital and is an internationally recognized expert on infectious diseases. Dr. Schuchat first joined the CDC in 1988 as an Epidemic Intelligence Service Officer and has been CDC's Principal Deputy Director since 2015. And Dr. Nancy Messonnier has also began at CDC as an Epidemic Intelligence Service Officer in 1995 and is now the Director of the National Center for Immunization and Respiratory Diseases. We very much really appreciate the opportunity to speak with all of you today. We look forward to hearing an update on the pandemic and CDC's ongoing efforts to crush the virus, to save lives, and to help the country resume everyday activities. And with that, let me recognize the ranking member of the subcommittee, Congressman Tom Cole, for any remarks that you would like to make, Congressman Cole.
Thank you, Madam Chairman. I have a set of absolutely brilliant opening remarks here, but I'm going to forego them in the interest of time. But I do want to make 2 quick points. The first is to associate myself with your remarks in terms of your gratitude to the CDC and the staff and all the brilliant professionals there and the job that they have done for our country and frankly for all of humanity during the course of this crisis. We've certainly had some ups and downs and some setbacks, but I don't think any of us have ever questioned the commitment of the folks at CDC and their hard work on our behalf. And I appreciate you pointing that out and again, associate myself with your remarks. The second thing, and I'll deal with some of this in questions, is just to thank the CDC. I know you've had to make some pronouncements sometime with less information and data than you might like to have, but I particularly appreciate the strong stand on school openings and the need to have kids in the classroom and our ability to do that with appropriate precautions and distancing. I just point out for the record, I actually have a son who's a public school teacher. And his school, which is a high school in an urban and suburban area, has been functioning since August of last year on a 5-day-a-week basis, and they've been able to do it without too much disruption. And again, I think your guidance in this area has been exemplary and spot on point. So I'm very interested in the other things that you have to say. Look forward to this, Madam Chair. Thank you for holding the hearing, as always, and I yield back the balance of my time.
Dr. Walensky, I understand that you have to leave us around 10:45 a.m. this morning, and that Dr. Schuchat and Messonnier will be with us until 11:30. So I want to say thank you again to all of you. And Dr. Walensky, we will now turn to you for an update.
Thank you, Chair DeLauro and Ranking Member Cole, for your invitation to speak to the subcommittee today and for your early and sustained leadership in the U.S. response to COVID-19. I'm accompanied today, as you note, by Dr. Ann Schuchat, Principal Deputy Director of CDC, and Dr. Nancy Messonnier, Director of the Center for Immunization and Respiratory Diseases. I apologize in advance that I do, in fact, have to sign off at 10:45. I'm enthusiastic to say that I'm presenting this morning at our National Forum for COVID-19 Vaccine. Drs. Schuchat and Messonnier will stay on and continue this important discussion. As you are aware, COVID-19 cases are decreasing in the United States. As of February 21st, the weekly average number of cases has decreased by 28.5% over last week's average, and the number of deaths has decreased by 25% over the same period. While we feel hopeful, the average daily case rate is still tens of thousands higher than the rate seen last September, before the cases started to rise in the fall. We are in a race to stop transmission. Variants have emerged, and available data suggests they are indeed more transmissible. Questions remain about how these variants will impact vaccine effectiveness, severity of disease, and mortality. We must continue to use every tool we have to fight this virus: wearing masks, social distancing, hand washing, and of course, vaccines. The scale of this unprecedented emergency requires unprecedented action. At CDC, over 8,000 CDC personnel have responded. Over 1,500 staff have taken part in nearly 3,000 deployments to over 250 cities across the United States and abroad. CDC continues to ensure that public health decisions are based on the highest quality scientific information. Since the start of the pandemic, over 200 COVID-19 studies have been published in the Morbidity and Mortality Weekly Report, and the CDC has produced nearly 5,000 guidance documents to provide information for government agencies, businesses, and the public. With new resources proposed in President Biden's American Rescue Plan, we will be able to scale up the public health efforts needed to contain the virus through 6 critical priorities: a comprehensive national vaccination program, increased testing to protect at-risk populations, expansion of the public health workforce, protection of vulnerable populations, commitment to U.S. leadership in the global response, and enhanced surveillance to identify emerging strains. Over the last 12 years, we've faced 3 significant infectious threats: pandemic H1N1 influenza, Ebola, and Zika. Even with its own funding approach to get out of the urgency, but none resulted in a foundational improvement in the public health at large. That lack of preparation led us to real challenges that we face and continue to face in COVID-19. Now we know the public health emergencies, and specifically infectious threats, are indeed here to stay. Looking to the future, I want to work with the administration and with you to address longstanding vulnerabilities through sustainable investments in core public health infrastructure, including data, workforce, laboratory, domestic preparedness, and global health security. These are issues that cannot be addressed through piecemeal emergency funding. To avoid the substantial economic costs associated with both large-scale emergencies and chronic public health concerns, we must be willing to take long-term, longitudinal investments. The CDC COVID-19 Health Equity Strategy addresses the stark health disparities and inequities that this pandemic has highlighted. African Americans, Latinx, and Native Americans are being hospitalized and are dying at disproportionate rates, not just of COVID-19, but of all diseases. Now is the time to scale up our work to better understand and combat how systemic racism contributes to health inequities. I look forward to working together to address both the immediate challenges ahead in our fight against COVID-19, but also, importantly, to address the weaknesses in our public health infrastructure that left our country vulnerable to this pandemic. We at CDC are grateful for your support, and we will continue to work tirelessly to ensure the health of the nation and the world. Together, we can build a sustainable and resilient public health system that can respond effectively to emerging threats and also to the ongoing public health needs of every single American. Thank you.
Thank you very much, Dr. Walensky. Let me just say, apropos of your comments on public health infrastructure, this subcommittee will have a formal hearing tomorrow on just that topic, the public health infrastructure, what we need to do, what kinds of investments, where are the shortfalls, and how we can, through this a subcommittee, address that very, very issue. It has been a priority of this subcommittee for the last 2 years, with funding a data modernization initiative in 2 appropriations cycles. With that, let me just say, in an effort to get in as many questions as possible by 11:30, the roundtable is being held remotely. We're going to use 3 minutes during each member's questions. It's an informal discussions, but I want members to be aware of the timer so that we can keep the discussion moving. So let me begin with my question. You mentioned this, Dr. Walensky. Variants of the coronavirus are concerning, pose another challenge to our response. Unfortunately, the U.S. is currently not doing enough genomic sequencing to identify the variants quickly enough. I was pleased that the administration announced nearly $200 million to CDC as a quote down payment to expand genomic sequencing to identify new variants. My question, what are CDC's plans for the funding? As you know, we are proposing an additional $1.75 billion for genomic sequencing in the American Rescue Plan. That would bring us up to about $2 billion. How is CDC going to increase our genomic sequencing abilities to contain the spread of the virus and detect what's next?
Thank you for that question. Let me just sort of set the stage as to where we are this morning. As of this morning, we have about 1,767 cases reported in 45 jurisdictions of the B.1.1.7 variant. This is the increasingly transmissible variant emanating from the UK. We have 5 cases in 4 jurisdictions of the P1 variant. This is the variant coming from Brazil. And we have this morning now 43 reported cases of the B.1.351 variant. This is the variant that originated from South Africa that is now found in 12 jurisdictions. We know about these variants because we have already been scaling up. So let me tell you about what we're doing now. We have received a down payment on the increase in sequencing that we are planning, and that planning has already emanated into increased sequences. When I started, we were doing about 250 sequences per week. We are now doing about 14,000 sequences per week, and that is about 3% of cases that we know about now. That obviously needs to scale up. So here is what we're doing to scale that up. We have partnerships now with the state labs so that each state is giving us about 700 or a total of 750 per week. So we get geographic distribution. This is through a system called the National SARS-CoV-2 Strain Surveillance System, the NS3. We're getting those from all 50 states and from the total of 64 different U.S. jurisdictions. We are also working with these jurisdictions to support the state and local health departments, both with money, but also with technical support, because it's actually not just that you have to sequence the virus, you actually have to know the science to do the genomic analysis. We are working with our academic institutions, at least 7 of them, with more coming, so that they can do sequencing as well, about 4,000 per week. And then we are working across the commercial labs so that they are scaling up to do now 6,000 sequences a week with more to follow. So all of those bridging of collaborations with the state labs, increased state lab capacity, as well as academia and commercial labs to really scale up to the place we need to be.
That was just within the 3 minutes, and so let me yield now to the ranking member, Congressman Cole.
Thank you very much, Madam Chair. First, Director, I want to thank you for your emphasis on long-term sustained funding. That's something this committee's worked on for 6 years in a variety of these areas on a bipartisan basis, and we've generally done more, honestly, than the administrations of either of the last two have asked us to do. So I look forward to a really robust plan and budget proposal. I know it takes a while to put that together, but as important as this immediate reaction is, as you pointed out in your testimony, it takes more than the immediate response. We've got to leave something behind that lets us build on it. And I know that's the aim of this subcommittee. So we look forward to working with you on that. I have a specific question related to the current crisis, though. Right now, of course, we're in a shortage in terms of vaccine. We have more people that want it than can get it right now. But I can see a time, not many weeks down the road, when we might be in the opposite situation. That is, actually have an abundance of vaccine, but we've got a resistant part of our population, up to maybe 35% that are expressing reluctance to take the vaccine. So I know you're surely thinking about that at CDC. What are some of the plans you have to help us persuade people when we have the supply available that we really need them to come in and participate with the rest of us and take the vaccine?
First of all, I want to thank you, Representative Cole, for your support. We are really grateful for that. We have lots of activities that are ongoing in this space in terms of vaccine confidence. First of all, I think we all have to recognize that people may be hesitant to take the vaccine for many different reasons. They may feel as if the science has been too rushed. They may feel that they're not at risk. They may feel that it's not convenient for them. So hesitancy comes in what I would say a lot of different flavors, and we need to really address them and understand them. We are doing a lot to ensure vaccine confidence and to work towards vaccine confidence. And I think you're right. I think at some point we're going to have this inflection point where we soon have more vaccine than we have people lining up to get it. And that's really where the work of vaccine confidence. First of all, I will say today I'm really thrilled that we are day 2 of our National Vaccine Forum. This is 11,000 participants from all 50 states, community-based organizations, faith-based organizations, academia, 128 tribal participants coming together to learn best practices of what they've done in their states, in their jurisdictions to improve. And that is where I'm going to speak at 10:45. I will say that we are also doing work. We have vaccine confidence consults, so people are able to call the CDC and understand how they can ensure vaccine confidence. We have toolkits. We have rapid assessment guides so that people can go into their community and understand where the issues are with vaccine confidence. We are building on previous investments that we have made in vaccine work. We do know that vaccine confidence is not just with the COVID-19 vaccines, but in fact with many other vaccines. And we're really enforcing our commitment to safety and working with the jurisdictions in all of these areas.
Thank you. Thank you, Madam Chair.
Thank you. Congresswoman Roybal Allard.
Dr. Walensky, as you know, Latinos have a COVID infection rate that is 1.3 times that of the non-Hispanic white population, but their hospitalization rate is 3.2 times greater, and their death rate is 2.3 times greater than their non-Hispanic white counterparts. These grave disparities are particularly troubling in light of an underlying long-term CDC issue you have inherited that I hope will improve under your leadership. In 1997, just a few years after I came to Congress, Hispanic Latino employees represented 2.6 of the CDC total workforce. To address the disparity, the 1997 CDC Hispanic Agenda for Action proposed an increment of 11% by 2005. Not only does CDC fail to meet that target, the current CDC workforce is even less now than it was in 1997. According to CDC's 2019 HRO report, there were only 220 Latinos at CDC out of a total of 11,400 employees. Additionally, at the CDC senior leadership level, only 1 out of 30 employees is Latino, And as grades increase, the percentage of Latino staff in leadership and senior positions decreases. In 2018 and 2019, a subcommittee of CDC's Latino Hispanic Health Work Group identified strategies to improve recruitment and retention of Hispanic Latino professionals, and they have yet to get any response on those recommendations. I hope that you will commit to addressing this long-standing disparity in the racial makeup of the CDC workforce. And I'm asking if you have any thoughts at this time as to what you will need from Congress to move this effort forward.
Thank you so much, Congressman. First of all, exactly what you say has hit me hard and personally. Our population at Mass General, where I came from, where I was on the front lines treating patients, was specifically the Hispanic community. And as we went from room to room, exactly the comments that you were saying were so vividly clear. We were in PPE trying to do translating in this community. So I very much deeply feel exactly what you are saying. I understand that we owe you feedback from a letter you wrote to us, and I know that that work is in progress and we will get that feedback for you. I regret for the delay in that. I also understand and I'm familiar with the 2018 report. My understanding from this report is that there is action that we are working to take, including increasing partnerships with Hispanic professional organizations, understanding why people, especially minority populations, including Hispanic populations, are not engaging in public health. And one of that is for debt, real issues with trying to create a career in public health, which is not a high-paying career when they come out of school with debt. We are working towards improving the Public Health Associates Program, which is popular in public health in terms of engaging minority recruitment. And what I will say, in my first all hands to this incredible agency, my remarks were really focused on my dedication to diversity, to equity, not just in the health of all people, but in the agency itself. So I am committed to that. One of the things I'm really hopeful will happen is that with remote work, we might be able to engage a more diverse workforce. I think that has possibility there as well.
Congressman Harris.
Yeah, thank you very much, and thank you, Dr. Walensky, and everything people do at the CDC. Let me talk about a topic that's very timely in the last week and this week, which is the idea of going to a single dose of the mRNA vaccines, similar to what they've done in Great Britain. And of course, we know Britain has a 50% higher vaccination rate because they've done it. Back of the envelope calculation is if we just went from a 21-day interval to a 42-day interval, which is acceptable now, we could vaccinate an additional 10 million people in the next 20 days. Because we would stop giving second doses, we just go out to the vulnerable and the essential people, administer an additional 10 million doses. Now, the FDA is about to consider the J&J vaccine, and the efficacy of the J&J vaccine as a single dose appears to be about the same as a single dose of the mRNA vaccines. So my question is the CDC going to, in an effort to increase the number of vaccines out there, because as I know, we still don't have enough vaccines. We have more people who want the vaccines now than vaccines available. We could simply do this by going to a 42-day interval. And I believe that the emergency use authorization should be changed. I understand normally the drug manufacturers have to do it, but I think the secretary would have the discretion to do it. What are your thoughts on this in order to get more vaccines out right now safely, according to the data that has come forward in the last 2 weeks?
Thank you so much for that question. Obviously, that has been a hot topic, so I know others are talking about this. First of all, I will say that the authorization of 3 weeks versus 42 days or 4 weeks versus 42 days, depending on the vaccine, lies with the FDA. It doesn't line with the CDC. So we are deferring that decision, of course, to the FDA. What I will say is I suspect that when Pfizer and Moderna were developing these vaccines, they were not interested in having it be 2 doses. It would certainly be beneficial to them to have it be 1 dose. And so I know when they were doing their early studies, they did look at 2 doses because at a single dose because one dose was harder. One dose was easier. They wanted one dose because 2 doses was harder. In that context, I will say that what we do know is the robustness of the immune response is much stronger after 2 doses than after 1 dose. What we don't know scientifically is how robust that immune response would be if we waited for 42 days rather than just either 21 days or 28 days. So I understand the interest in that tactic, but I will say that there are 2 things that make us really worried about it. Well, 3. One is the scientific trials did not study it. Second is we don't know the durability of it, how long that vaccine will last if we wait. The studies certainly show that at 3 and 4 weeks you have a good response, but we don't know what happens if you only have 1 dose and you wait 5 or 6 weeks. We just don't simply have those data. And then third of all, we do know in vitro studies in the lab that these vaccine responses are not as neutralizing against variants. And so we really do believe that we need the robustness of that 2-dose response if we are potentially going to tackle variants such as the B.1.351. So I think in the context of the concern both about durability and also about the variants, and because the FDA has authorized it at 3 and 4 weeks, we at the CDC are now still sticking to the 3 or 4 week plan.
Okay, thank you.
Congresswoman Lee?
Thank you very much. Thank you, Dr. Walensky, and congratulations to you. In any pandemic, it's really imperative that trusted messengers, such as community-based organizations, faith-based organizations, and nonprofits play a supporting role in reaching communities that are historically and medically underserved. Now, as you know, we secured $2.8 billion for testing, tracing, and vaccine distribution, specifically for communities of color within our most recent COVID relief package. Now, equitable vaccinations, testing, and tracing can really be, and you know this, and the full committee, the subcommittee understands this very clearly, could be the difference between life and death, especially for Black and brown people. So let me ask you, in terms of implementing strategies, how do you intend to implement these strategies just based on this initial $2.8 billion to make sure that we hold state and local health departments accountable to work with community-based organizations to hire and train trusted messengers? And then secondly, just how do you intend to implement strategies to address systemic racism in our healthcare system? Because this is historic, it's structural. Senator Warren, myself, Congresswoman Presley, we introduced the anti-racism and public health legislation. Parts of that legislation, I think, could be implemented now. This is an emergency, and I think the COVID pandemic has really highlighted the issues, the structural issues, as you mentioned, that have been longstanding in our country. So we have to do something quickly. Thank you again.
Thank you so much, Congressman Lee. I will say this has been something that's near and dear to my heart, and I know you and I have intersected in places you may not be aware of in my work in HIV/AIDS and the International AIDS Society, so I want to thank you for that as well. I do want to say that we have been working across agencies to try and do this outreach to get vaccines specifically to these communities. What I am really anticipating and I'm hopeful of is that given the light that has been shined on these inequities, especially in this pandemic, and the lessons that we're learning, the outreach that we're learning, how we place community vaccination centers in areas of highest need, how we get vaccine to pharmacies in areas of highest need, how we work with the federally qualified healthcare centers to reach those in highest need, that we can leverage everything that we've learned in these processes and maintain them to make sure that not only are we have them there for testing and for vaccination and for distribution, but we've continued these partnerships that we've done with community-based organizations and faith-based organizations, not just through COVID, but through all areas of health. I feel like if we don't take this current moment to leverage what we've learned and make sure that it's sustained after this pandemic, we will have lost a huge opportunity to do an amazing amount for public health.
Okay, Congresswoman Herrera Butler.
Thank you, Madam Chair. And I wanted to look a little bit about school reopenings and school closures and students' mental health. I know in the past year, CDC documented that mental health related ED visits increased 24% for children ages 5 through 11 and 31% increase in children 12 through 17. And in your operational strategy to reopen schools, you only mentioned the mental health piece twice. Well, we're seeing schools creating suicide alert systems for and programs to help, really, because they're seeing increased hospitalizations. Do school closures or have they had a negative impact on students' mental health? And why were studies like this not necessarily included in your operational strategy to highlight the impact of prolonged school closures on our nation's school children? And I'm going to add Como News, this was at the end of January, it was an article about what was happening in Nevada, but it was the nation's 5th largest school district announced it would start in-person classes after 18 students committed suicide, a majority of those in the last 6 months. And I just thought it was really important. One of the administrators, the superintendent, said, when we started seeing the uptick in children taking their own lives, we knew it wasn't just the COVID numbers that we needed to look at anymore. I mean, I think their youngest student was 9 years old. And so I wanted to highlight this and maybe offer that up and ask for your comments.
Thank you. I'm a mother of 3. So those comments hit home. I completely understand and sympathize with the challenges of having children home and the tragedy of the mental health loss. I will say that has occurred during this pandemic. So I hear you. I'm with you on this. A few things I want to note. First of all is that the strategy was actually a strategy to get things opened for exactly the reasons that you comment. I firmly believe, I know we at the agency firmly believe, that in addition to mental health, there's been domestic violence, there's been food insecurity, there have been many things that are not listed in our opening strategy because it was really a guidance and strategy to open. But you are right to highlight that there have been many detrimental effects of having the schools closed. I do know that CDC has been supporting public mental health efforts for the children who have felt heavily this impact of school closures, including providing 22 current division and adolescent health funded programs that look at creative health, healthy learning, affirmative learning, and many other programs so that we can support the students during this time. We have ongoing studies and ongoing surveys that you'll be hearing about shortly that have looked at what the mental health detriment has been to our children. We have needed to do those studies in order to report on them, but we have, as soon as the school had closed, we knew that this was going to be a challenge, and so we have been actively doing both student surveys as well as parent surveys, so we will have data on that. But those data necessarily will lag, and what we really need is to follow this guidance so that we can get the children back to school.
Thank you. Congresswoman Frankel, before the Congresswoman starts, let me just, all of us offer you our congratulations, a grandmother for the 2nd time here. Little boy, little girl, come on, Lois, tell us.
Beautiful little boy named Bruno.
Okay, all right. Welcome, Bruno.
Yes, thank you, Madam Chair. Are we going to get to question our other guests later?
Well, Dr. Walensky will leave at 10:45, and Dr. Shukin,
Okay.
Dr. Messer.
All right, so because I will have some grandmother questions.
Okay.
All right, but I do want to start with thank you all of you, Dr. Walensky. I want to just tell you what's been going on the ground here in Palm Beach County, Florida, just to give you some insight. Palm Beach County has about 1.5 million people, probably about 350,000 people over 65, just to give you a sense of it. Our governor almost right away, it said vaccines would go to anyone over 65, and then also started with essential healthcare workers. What happened in this county is that the vaccines were originally going through the health department. There was probably about a 200,000 waiting list, got whittled down to maybe 100,000 when the governor decided that here in our county, all the vaccines were going to go to the public supermarket, which was located only in white middle class neighborhoods. So of course there's been pushback, but here's what's been a result of that. The health department has pretty much left out of the loop. And so the health department is, we've gotten some vaccines for the underserved communities, but here's what's happening. I was on a Zoom with a hospital. They got 25 new nurses, no vaccines for them. No vaccines in a lot of the underserved communities. So my question really is how much are you leaving the decision of where these vaccines go to the governor? And what attempts are you making to actually get some input from our public health departments?
Thank you for that question. First of all, congratulations to you. So I think that's a multi-pronged answer. First is the state supply does in fact largely go to the governors, and in many states, I would hope in most if not all states, those governors are talking to their experts, their state health officials, their local health officials. What I'm hearing from you and what I know from others is that is actually not the case. What I will say is to the extent that some of that supply gets deferred to the governor, the state supply gets deferred to the governor. The federal government is working hard to ensure that there's also supply going to these hard to reach communities. So community vaccination centers are intentionally put in collaboration with the CDC and FEMA to in places with high social vulnerability index to ensure that they are reaching those hardest hit populations. Our fentanyl pharmacy program is heading to pharmacies that are intended to reach hard to reach populations. Our FQHC program is really going to places where they have more undomiciled or marginally housed or public housing or migrant workers. So really it's intended to go, so many of these federal programs, if the governor is not distributing them to, as we would hope, to the places where places have been hardest hit, that at least our federal programs are heading in that direction as well. And we do hope with more vaccine coming that there will be more supply heading into those places. I think I do have to take maybe one last question before signing off.
Okay. Congressman Molinar.
Thank you, Madam Chair, and Director Walensky. Thank you for being here. And I know you're time crunched, but my district is fairly rural, and you've mentioned accessing, hard to reach communities. Rural areas have unique challenges. I wonder if you could speak to some of those challenges and also how CDC is working with state and local public health departments to ensure that rural communities with much more limited healthcare resources are being supported.
Great. I think what I will say is much of the work is going to in our partnership with these localities, because we do recognize that the states and localities have the best reach of understanding how to get to those hard to reach populations. What I might do is actually ask in my departure, Dr. Messonnier, to take this on, because I know she's been working hard in this space as well. And maybe I will just say thank you to all of you, and I look forward to collaborating with you. I know you all have been incredible supporters of CDC, and so I'm looking forward to much more of that ahead.
Before we shift to Dr. Messonnier, Congressman Molinar, I just want to say a thank you to you, Dr. Walensky, very, very much. And look, we all know that CDC has been silenced, sidelined. Thank you. We'll talk to you more about how you need to rebuild the agency and the public's confidence in CDC's role, and most importantly, how this subcommittee can help you to do that. Thank you very, very much for all that you are doing, and thanks for being back on track. Appreciate it. Okay.
Thank you so much.
Now, Dr. Shuka, do you want to respond to Congressman Molinar's question?
I think we were going to have Dr. Messonnier talk about the rural
Fine.
vaccine. Hello. Can you hear me? Because I can't hear you. Okay.
Yes.
Thank you.
Okay.
Thank you. So what I would say to start is that every community has its own challenges. And that's why we're working, frankly, every day with local and state health departments to understand their challenges, but also to understand the best practices and to share between one state and the next the best practices. This phase of the vaccine program is especially challenged by the two vaccines we have that, while very effective, are more complicated because of the way that they're packaged and the cold chain requirements. And that makes it especially difficult for rural areas where populations are spread out and the cold chain requirements become especially problematic. We're working closely with the health departments, but we're also working closely with the variety of partners to look where the most convenient places are to put vaccines, even in rural areas. For example, it turns out that pharmacies are great partners in rural areas because in many places where there isn't a healthcare provider, there's actually a pharmacy. And so we're really working to map out in each state at a much more local level where the access points are for vaccination. And also, as vaccination coverage starts to come up, we'll be able to identify what we call vaccine deserts, places where there isn't sufficient access to vaccine. And we'll work with the state health departments, but also these federal programs to really make sure that we're getting vaccine to where people need it.
And if I could follow up on that with the supply chain, how are people finding out, what number of vaccines are available? Because they're trying to communicate that out and schedule vaccinations with people. And again, in some of these rural areas, they're driving an hour to go to the location, and sometimes they find out they don't have the vaccine available. What's the process on that?
The process at the moment is imperfect, but we're working hard to try to make it better and easier for the customer who shouldn't have such a difficult time getting access to vaccine. And especially for people who are not very IT savvy, it is especially difficult because a lot of the systems nowadays are very much built around having access to a smartphone and knowing how to use it. The best source of information currently is the health department, the same place that someone checks to figure out what COVID circulation looks like in their community is the best current source. But we're also really working to try to make this easier, including finding ways that people who, again, are less IT savvy can have access to appointments, working with community-based organizations as well as local health departments to really facilitate the scheduling of appointments. When we planned for and thought about a pandemic, as many things that we thought about, we never really fully realized we'd have to be doing this in the midst of social distancing. And it has made lots of things, including getting people to vaccine, much more complicated because we don't want people standing in line, of course. We want them to have appointments so that we can minimize the time that they're spent. So what I would say is there are systems now, they're imperfect, but we're really, really working hard to improve them.
Okay, thank you. Thank you, Madam Chair.
Thank you. Congresswoman Bustos.
Hey, hello.
Yes, we can hear you.
I'm sorry. I've been having computer problems. I know Dr. Walensky got off. I have a question about COVID at prisons. Are we in a position where somebody would be able to answer that question for me? Hello?
Thank you.
Dr. Messonnier?
Yes, thank you. I can talk specifically about the immunization programs in prisons, and maybe Dr. Shuckett would want to add more broadly.
Okay. Well, let me drill down a little bit before I just wanted to make sure that one of you was in a position to answer since Dr. Walensky got off. So here's my question. We have 2 federal prisons in the congressional district that I serve. And then if you look at nationwide, the Federal Bureau of Prisons has about 36,000 staff. And already about more than 6,400 there have had confirmed cases throughout the pandemic. So nearly 1 in 5 staff members. We've had, there's been 4 staff deaths, including in my own congressional district. So this was just a huge, huge wake up call for us. We had a correctional officer, MacArthur, who was at the Thompson prison, only 42 years old, and lost his life to the pandemic. And, just a couple other facts, because I think it's worth sharing with my colleagues here too. In the Bureau, out of more than 137,000 inmates, there have been almost 48,000 confirmed cases, including 222 deaths there. So again, that's more than 1 in 3 inmates who have had COVID. So just some real issues here. I have other facts that I can give you, but I know we're limited on our time, but just really want to know what is being done on vaccinations for staff, and what conversations have you or will you have with the Bureau of Prisons to help ensure that this mess caused by the previous administration is brought under control? And so if you could start with that, that would be good. And I'm guessing we'll be out of time by the time you answer those questions.
Just keep going. Go ahead.
Yeah, thank you for raising this really important issue. CDC has actually been collaborating closely with the Bureau of Prisons to address outbreaks and advise on mitigation measures. In fact, the Bureau of Prisons was specifically chosen as a federal entity to receive vaccine directly because of its nature as a congregate setting and the contained separate population. We began working with the Bureau of Prisons early in the fall to help them put together plans so that when vaccine was available, they would have plans in place to use it. In the last H1N1 pandemic, the allocation of vaccine directly to Bureau of Prisons was really seen as an advantage, and so we continued with that model. As of yesterday, the Bureau of Prisons has received around 50,000 doses to vaccinate all the Bureau of Prisons managed facilities, including staff and incarcerated individuals. Now, that's not enough for everybody, as you point out, but I do think it's a great start. And I will also say that the Bureau of Prisons, because they did have time to do such great advanced planning, has been very efficient in their use of that vaccine. Dr. Shuckett?
Yeah, I think the only thing to add is that early in the pandemic, of course, we were deploying to assist some of the prisons and also jails with understanding the transmission and trying to strengthen preventive measures. Congregate settings are a big risk for this virus, and understanding about masking and testing protocols was very important. So we have updated guidance for correctional settings and are continuing to update our recommendations as new data emerges.
Okay, it's very much needed. I'm out of time, but we could drill down maybe offline. Thank you so much. I yield back, Madam Chair.
Thank you. Congresswoman Watson-Coleman.
Thank you, Madam Chair. Dr. Walensky was talking about the fact that there was going to be a point where we have more vaccines than we actually have people who are willing to take them. I want to know, does anyone have any idea when that would be? Because particularly in the African-American communities, we could use that advanced information to ramp up some additional outreach and preparation. And then I also wanted to know, can anyone tell us when they think that the Johnson one-shot vaccine is going to become available? Those are my questions.
Thanks so much. Let me begin and then let Dr. Messonnier continue. You know, I think there's not going to be a single date where the entire country has more supply than demand, and I believe we will see inflection points locally. You raised the issue of the African-American communities. We need to start planning now because there are some areas where reluctance to be vaccinated is greater for very understandable reasons. So part of the idea of this vaccine forum that's going on right now with 11,000 people from around the country is to both identify the best practices for efficient delivery in this low supply, high demand period, and also to understand about vaccine confidence and measures to try to strengthen demand when we have tons of supply.
Thanks,
the
Doctor.
issue.
Do you think you have any idea when the supply will kind of be close to the demand? Are we talking about 3 or 4 weeks? Are we talking about a month? What are we talking about?
I think it's longer than a month, but let me let Dr. Messonnier give a little bit more detail.
So
Thank you.
I think you're asking two questions, which are hard to
Yeah.
answer. One answer is that we're told that there should be enough vaccine by summer for everybody to get vaccinated. Excuse me. So that means that we have until summer to get all of our systems moved so that we are ready to move people quickly through that vaccine to take full advantage of it. And we have till summer to build the tide of public opinion so that everyone is willing to roll up their sleeve. I am hoping that there's never going to be a point where there's lots of vaccines sitting on the shelf, because with your help, we're getting the message out to people about this vaccine being safe and effective and an important tool in getting us back to normal. But it's going to be hard. It's going to be hard every day.
You. And when do you think the Johnson vaccine will be available?
Thank you.
To
That's
the best of your knowledge.
Question. Yeah, that's a simple question. FDA's advisory committee is meeting this Friday. That is the pathway to an emergency use authorization. The next step is CDC's advisory committee. They're meeting on Sunday and Monday. If FDA authorizes use of this vaccine under an EUA, then ACIP will be considering recommendations for its use. And that should be on Sunday. Yeah. And that means the vaccine may be available as early as next week.
Thank you. And there's vaccine already available, J&J, in anticipation of getting the, okay. Thank you. Thank you very much. Thank you, Madam Chair.
Just to add something, the issue of systems being up and running. I had the opportunity to be at the Veterans Hospital in my community, which is the hospital for the state of Connecticut. And they have devised a system which is really incredibly efficient. They get veterans in and out in about 20 minutes. And people go to for first dose in one line, second dose, et cetera, works very well. Two issues on the hesitancy issue is when they've seen the decline rate in people coming, it is largely because folks have said that their spouse or their caretaker has not been vaccinated, so that they are transportation is another issue, but supply as well. If they had more supply, this particular VA center said that they could do up to 1,000 people a day. So, but getting these systems up and ready, I think, is critical. And your point well taken, Congresswoman. Congressman Harder.
Thank you so much, Madam Chair, and thank you so much for our guests joining us. I think my question is probably for Deputy Director Shukit. Over the past year, I think all across the country, but especially in our district in the California Central Valley, we've seen our local public health officers really overwhelmed. They've been working heroically, doing their best, but they've really had some challenges dealing with the scope and scale of this pandemic. I know historically, public health agencies like the one in our district have been funded primarily by state and local dollars, but I think this pandemic has also shown just how interconnected we are on public health issues. So I really have two questions. First, roughly what percentage of the CDC's budget for public health preparedness today makes its way into local communities to improve capacity? And second, what do you see as the role of the CDC in scaling up this local public health capacity and trying to address some of the challenges that this pandemic has revealed? Thank you.
Yeah, thank you. You know, CDC's budget primarily goes to state and local public health. More than 60% of the entire budget is headed that way. And during this pandemic, we have put more than $35 billion out to state and local public health to be on that front line of support. But I think, as Dr. Walensky pointed out at the beginning, the emergency resources are very different than sustainable longitudinal capacity. And what we are really suffering with this time is that weakened infrastructure and ability to be ahead of the curve. So we've been chasing this virus and behind it from the beginning, very much because of the burdens on that state and local front line. We have a lot of priorities around improving the data, improving the workforce skill sets, improving the lab capacity, which is also a frontline issue, and the outbreak responsiveness. But even though the bulk of our money does go out to state and local, it's not been enough for us to be fully prepared for this pandemic. Thank you.
Thank you. If you have suggestions, we'd love to take this offline on ways that we could improve some of that emergency responsiveness and try to make sure that we're taking it to more sustainable levels. One other question, I think the director mentioned the Community Health Center vaccine program. I know that's primarily through HRSA, but there is a role for the CDC. I've been trying to get a straight answer on whether or not a facility specifically in my district has been selected for that program or not. It's been a little bit unclear. So we can get some confirmation from you or anybody on your team on that one way or another. That would be very, very helpful. Thank you.
And we'd be happy to follow up offline on that one.
Thank you. You're back.
Congressman Pocan?
Thank you very much, Madam Chair. I'm sorry I had another committee earlier, so I apologize for not being around. I have been getting an update on questions, so hopefully I'm not being redundant. I have had a couple concerns from the state of Wisconsin, and one I think Bonnie Watson-Coleman kind of asked, which is what you could tell us about anticipated vaccine supply in April, May, and June to assist in planning efforts and management of public expectations, and then what the approval of a third COVID vaccine meant. So if there is anything additional, you can respond to that. But she also asked us to relay that we've had now 6 cases of the B.1.1.7 variant, and they're concerned about messaging as they're dealing with trying to get this out. One, messaging about the additional ongoing testing that's needed because our testing has started to drop off, and also genomic sequencing. Can you please comment on any specific strategies that you and others are using to control the spread of variants right now?
Yeah, let me begin with the variants, and then Dr. Messonnier can add a little bit about what we expect with supply in the spring. The emergence of the 117 variant has gone very quickly, and so that is the most common one we've detected. The good news is the things we've been trying to do to slow spread and contain this virus are the same things that work against the variants, but we have to be very, very vigorous. You know, consistent mask wearing, physical distancing, avoiding crowds, no non-essential travel, very important to prevent the variants from what we expect will be a rapid emergence. The issue of testing, we are strongly recommending testing, and part of the recent funding announcements have been to enhance testing availability, to strengthen the ability to test in schools, for instance, to get testing out to areas of highest need. CDC is updating our guidance on testing to really make it very easy to get it and to help jurisdictions understand how to optimize testing information. But the critical issues of isolation and quarantining related to a test positive or a contact of a case hold, whether it's the variant or not. Want to talk about the supply?
Yeah, sure. So maybe just to say that there are a variety of efforts underway to increase the available supply of vaccine. My understanding is that there should be enough vaccine for everyone by summer. That certainly I know feels a long way away. I also understand that really within a couple weeks we should see an increase in the pace of vaccine availability through efforts to maximize vaccine both from Janssen, but frankly also from Pfizer and Moderna. And I'm certainly looking forward to seeing the fruits of those efforts, you know, in March and April as we build to enough supply by June.
Thank you. Yield back, Madam Chair.
Thank you. Congresswoman Lawrence? She may not be on yet. Let me ask, because I think there probably may be several more questions. I know I do, and Congressman Cole, so let me just continue. Let me just ask you, Dr. Schuchat, I know you have been charged with a comprehensive review of all of CDC's COVID-related guidance. That's my understanding. Can you give us an update on that effort and when there will be additional updates to be released? And you know, you know, where you want to go. And I want that. And I would just love to get in another question as well, as if I could here. So.
Sure. In brief, I've been working closely with the incident management system, our leadership of the response for the year, to identify areas that are in critical need of updated guidance, areas that we should take down guidance that we have, and really importantly, ways that we can make our guidance much clearer, both in the web presentation and in the way that we describe it when it comes out. It's critical that we have the public confidence in CDC's guidance, both the public's and our public health and professional stakeholders. So I'm pretty close to finishing, and I've been meeting with Dr. Walensky about my findings so far.
I think that would be enormously helpful in getting the trusted voice of CDC back to being the trusted voice that it has been in the past. And so we're cheering you on in that regard. And I think the American people will cheer you on as well. They have been confused, and help please unconfuse them, and with yourselves and the administration to give scientific guidance to folks. Let me just ask, this has to do, and either one of you or both, in December we did emergency funding, $8.75 billion for vaccine distribution. The American Rescue Plan has got a significant amount of money to ensure hundreds of millions are being vaccinated. Tell me how CDC is working with FEMA on its efforts to open mass vaccination sites.
Thank you. And I want to start by thanking you for the tremendous support. It really has been a game changer as we seek to vaccinate the entire country in a real unprecedented way. We've been actually working incredibly seamlessly with FEMA. One of our staff is deployed to FEMA and leads a team, and we are working with them every day around standing up these community vaccination centers. That is both at a technical level, helping them assess where the best places to put these CVCs, community vaccination centers, are in states. With the stand-up of those first centers in California, we had staff on site working with FEMA around lessons learned so that we can continue to improve those efforts. We're also working with FEMA around equity, communication, data, frankly, every sector of work. And it's been, I think, a really great partnership.
Okay. Thank you. Thank you very, very much. And now let me recognize Congressman Cole.
Thank you very much, Madam Chair. Just quick, as an advisory note to you, I may have to leave a little bit early. I've got a lunch schedule with my governor, and I can't miss that one, particularly in a redistricting year. You'll understand.
Right.
But I have two questions for our panel, and they can either one of them can address both, or they can divide it how they want. The first one is to go back to this point about building things that last during the middle of a crisis. What things that we are purchasing now, we know most of this is immediate needs, but what things have you been able to do that might lead to enhanced capacity later that the committee needs to think about funding later? In other words, continuing the funding streams for as you develop them. The second is to go back to this variant question. You talked about 117, but obviously we have a lot of different variants popping up, some of which appear to be more secure. What are the efforts underway to both keep track of those and, again, try insofar as you can to get ahead of them a little bit so that as they pop up in the United States, if we need something beyond our current vaccines, a booster or what have you, that we have the capacity to do that?
Yeah, thank you so much. I think that there's several areas where the investments we're taking in this emergency are going to be critical for the long haul. The first one I want to point to is data, that because of the emergency, we have been able to accelerate the data ecosystem so that the data that's coming from healthcare to public health, the data that's coming from laboratories to be visible for public health action has just been extraordinary. We've gone to 6 million reports of electronic case reporting when we had almost nothing before. So this is just in about an 8-month period. But the the data work to come is even bigger. So I think we've been investing in a way that will be useful in the long haul, but it's really COVID focused and it's going to need to be broader than that. The second area is the workforce. You know, we are seeing at every level, local, state, tribal, as well as the federal level, the challenges in having a public health workforce that represents the country, that is able to handle the data or handle the laboratory needs or handle the cultural challenges that we see in Indian country and so forth. And we really are investing in both our recruitment and our public health capacity locally in ways that we hope will be here for a generation and not just this next year. The third area is around laboratories, and it speaks to the issue of the variants. You know, the UK is way ahead of us on genomic sequencing because they've invested in a system to actually have the laboratory specimens, be able to process them, and have the bioinformatics that can handle it. So this is an area of urgent need that we are working on. We have already been able to strengthen resources to state public health labs to increase their ability to do sequencing. Some of it's built on the investments that the committee helped us with around antimicrobial resistance and foodborne diseases, where we got some of that sequencing capacity, but it needs to be much bigger for the volume of issues that we're at. So we're nowhere near the rate of sequencing and analyzing the data and then jumping on it locally around those variants that we need to be.
Thank you very much. Thank you, Madam Chair.
Thank you. And I would just once again just say this. This is very helpful question, Congressman Cole, and responses as well, because again, tomorrow we are going to focus in on public health infrastructure. It's not the first time that in a bipartisan way, this committee has focused in on this issue, and particularly with regard to the data piece and now dealing with the workforce and our concern about the laboratory. So I think that this subcommittee has a very significant role in building that infrastructure for the future. Let us not go backward, but look at what we are doing for something that is building the architecture for the future. And I think that we have an opportunity to do that. So thank you again. Thank you for the question. Congresswoman Lucille Roybal Allard. And don't miss your governor. Congresswoman Lucille Roybal Allard.
Dr. Messonnier, it's been a little over a year since you were before the subcommittee warning us about a new virus that was circulating in China and predicting that we would need to take drastic measures to prevent its spread across the US. You were one of the first to speak the truth to Congress and the American people. And as a result, you were sidelined and not allowed to share your science with the public. So I want to thank you for your courage, and I am very pleased to see you and Dr. Shuknik back again. Assuming COVID will be around for a while, what is your long-term view of returning to normalcy in this country? And can you elaborate on how long you think it will take for the US immunization infrastructure to be up to the challenges of not only containing the virus, but its variants over the next 12 to 36 months?
So I'll begin with the effort of getting back to normal and let Dr. Messonnier talk about the immunization infrastructure. You know, the first thing I want to say is that the timeline is dependent on us. Our efforts to consistently wear masks, to social distance, to take the vaccine when it's available to us will really influence the ability for us to get close to normal over the months and ahead. The variant is a wild card, just exactly what will happen with these variants, and we'll see resurgences that will take us further from normal. But I think, as Dr. Walensky's been saying, it's going to be more of a dial than an on-off switch in terms of incrementally more normal activities. As more people are vaccinated, individuals who are vaccinated will be able to do some of the things they couldn't do before. And then as our population is more vaccinated and we really suppress the levels through our social distancing and masking, we should be able to get back into social activities. I'm hopeful that by the end of summer, things will start to look a lot more like they looked a year and a half ago, but I think it's really dependent on our actions in the weeks and months ahead.
Thank you. I think maybe one thing I'll add is that I feel like sometimes people misunderstand the idea of us getting back to normal as being a one-time thing in the entire country. From a vaccine lens, we need to get vaccine in every corner of every community in the United States. And that's going to be hard, as we know, because some communities are hesitant and because access is an issue in some communities. So success is measured in a dial, but it also, in my mind, is measured in being sure that we're not leaving anybody behind in our immunization efforts, and that for communities that are hesitant now, we go back again in a few months and make sure that we keep going back until we really give folks the opportunity to take advantage of the vaccine. I also think we need to remember that this may require a long-term immunization program, not just a one-time push, but a maintenance program. It also likely will require additional childhood immunization, and the vaccines for children aren't licensed or authorized yet. And so I think from a vaccine program perspective, this is not going to be a quick fix. It is going to require long-term capacity and long-term effort across the health sector.
Congressman Harris.
Yeah, thank you very much. And Dr. Shakett, let me ask you, because I know the director's not here, and I didn't have time for a follow-up question, but very specifically, I'd like to know why the CDC doesn't think we should pretty aggressively look at extending that second dose interval to 42 days, because the interim clinical guidance already says, the CDC interim guidance says, yes, if you can't, for some reason you have to delay it, you can go up to 42 days. And there's little information about effectiveness beyond that. But the CDC has already said you can go to 42 days. The real world experience, the director said that, well, the studies were designed to show that the second dose gave a big boost, but that boost was in neutralizing antibodies. Real world experience when you combine that, might indicate that neutralizing antibodies might not be the only answer. Memory T cells might be. So pretty clearly, I think a case could be made that these drugs are pretty effective, and why not give a person a choice to delay that second dose to give another person the opportunity to get that first dose, which is 75% effective at preventing symptomatic COVID in the British data, which is real world data. So if you could just follow up on that.
Yeah, thank you so much. First, I want to say that Dr. Walensky and CDC are committed to continually evaluating the emerging science. I also want to say that we're committed to learning from the experience. As you know, we have a lot more people who've received one dose than 2 doses, and we're working in collaboration with a number of partners to evaluate the effectiveness of the vaccinations that are happening right now, just as some of that early data from Israel, was the early experience there, or the UK experience as well. So what I would say is that there is a very strong commitment to science on the part of Dr. Walensky, CDC, and this administration, and a very robust interagency process to look at the emerging science as it comes out. And so I would say this is one of those issues that is likely to be reevaluated very frequently.
So let me just follow up with that, because we're told that the FDA can't use real world experience in making their decisions. Do you think, and I know that Dr. Burgess, for instance, I think is going to offer an amendment in Rules Committee to the COVID bill right now to allow them to use real world experience. Do you think we should have the FDA look at real world experience and to make some of these decisions?
I can't really speak to the FDA. Let me just say that at CDC, we are very committed to real world experience. We would never have realized that the meningococcal conjugate vaccine needed a second dose without evaluating the post-licensure effectiveness. And so Dr. Massoni's center and the immunization effort here and around the country is very committed to observational data and making it as robust as possible. That's what we do with flu vaccine every year to measure its seasonal flu vaccine effectiveness, and we learn as we do that. So I again can't speak to the FDA's authorities.
Congresswoman Lawrence.
Madam Chair. Last year, I sent a letter to the CDC requesting information of COVID-19's effect on pregnant women. At the time, focusing on providing expected women with information on how to manage this pandemic. My question is, over the last year, what has the CDC learned about the virus impact on pregnant women in particular? And even though a clinical trial is just beginning, can you speak briefly to what pregnant women might expect as the trial continues?
Yeah, thank you so much for that question. You know, pregnant women have been understudied, and it's very challenging to get the best recommendations for women on how to protect themselves and their pregnancy in real time with an emerging infection. We have been actively reaching out and supporting research and studies in this area and working on surveillance. We were able to expand SETNet, which was really set up after Zika and the opioid issues as a surveillance for emerging threats to mothers and babies, from 11 sites to 28 sites, with plans to go further during this year. This is tracking women and their babies following COVID infection so that we can understand the consequences. The vaccine-specific effort is also trying to understand the impact on vaccine in pregnancy. We know that a number of women have already been vaccinated, and I'm going to let Dr. Messonnier kind of expand a little bit about how we are gathering data to provide information in real time for pregnant women. We think that this virus can be more severe in pregnancy, not as severe as we've found influenza to be, but we want to make sure that women and their caregivers or healthcare providers have the best information to make recommendations. Do you want to?
Maybe just to say specifically about the vaccination, we recognized that clinical trials of these vaccines were excluding pregnant women, but that pregnant women would be faced with the situation of having to make a decision about vaccination. So we started working early with the professional organizations that represent pregnant women and newborn babies to make sure that they're looking at the same data that we were as our advisory committee, so that when the ACIP made recommendations broadly for use of the mRNA vaccines, that was accompanied by recommendations from the professional organizations for pregnant women. There's a toolkit on CDC's website, as well as on the professional organization's website, to help pregnant and breastfeeding women and their healthcare providers make these decisions around vaccination, but also in a real effort to try to surmount the challenge of the absence of data. We launched a pregnancy registry that pregnant women are enrolling in after they get vaccinated, so that we can rapidly gather the most relevant and quickly be able to provide that information back to pregnant women. And it is gratifying to know that we have lots of women enrolled in those registries, but also that many pregnant women are choosing to be vaccinated. And this is especially true among healthcare providers, where they are able to weigh the risks and benefits, and a lot of them are going on to get vaccinated.
Thank you, and I yield back.
Thank you. And I would just say that I think the investment in this data modernization and the interoperability of the data has a profound effect on this issue of pregnancy, Congresswoman Lawrence. Congresswoman Herrera Butler.
Thank you, Madam Chair. I wanted to ask about your coordination efforts with state and local authorities to assist with administering the vaccine, and more particularly in rural areas. You know, we have a mass vaccine site in one of my counties, and everybody was excited about it, except for the fact that it ended up pulling the vaccines from the small rural areas. And the answer was, well, get online and get an appointment. And then if you're a senior in a rural area, you're lucky if you have. I mean, these people are dealing with dial-up if they have it. And so they literally were kind of getting pushed out. And I know in the matrix of trying to make sure, you know, certain, whether it's minorities or underserved populations have access, or vulnerable populations, they ended up getting kind of pushed to the back a bit. And I wanted to understand what your coordination efforts were, if you're seeing this, and if there's guidance that you're providing specifically to the states, because obviously they're directing. And I don't know who that, I would say, I'll just, yeah, I'll let you go for it.
Thank you for that question. And I want to start by saying that this is really difficult. It's difficult at a federal level, it's difficult at a state level, and it's difficult at a local health department where they're trying to balance speed and equity, right? In order to really move fast, you need to be efficient. But many of the populations that are harder to serve, harder to reach, where there's systemic racism, where there's access issues, those populations require more time, either because you have to geographically get vaccine closer or because you really need to do a lot more community engagement. And I know at the state and local level, just like at the federal level, they're really trying to balance those needs. How are we working with them? We're working with them every day to give them feedback on their programs, to look at their data with them, and to help them find solutions to some of these problems that are not simple. We're also working with them to really stand up some additional federal programs that we hope will help address some of these equity issues. And then I would point back to the forum that's going on this week. We have 11,000 people there from all across the United States. And part of the reason to hold this kind of forum is really to share best practices and lessons learned across communities. And so we have folks from faith-based organizations, community-based organizations, pharmacies, health departments, all cross-talking, because I really think it is going to take a whole of society effort to surmount these challenges. It's not a one-size-fit-all, even for every rural community. And the best way that we can learn and learn quickly is by seeing what's working and trying to take those lessons and apply them to other communities.
Congresswoman Lee.
Thank you very much, Madam Chair. Let me just ask about the genomic sequencing in terms of the virus variants. The UK and South Africa, they were able to discover these variants in their domestic COVID-19 cases using the genome sequencing. Okay, so now let me ask you in terms of variants, in terms of the representation of non-European populations in the human genetic studies. Of all the continents, Africa has the greatest genetic diversity. And I think it's called the founder effect. It's associated with the birthplace of human beings. So I wanted to find out if CDC is researching the whole genome sequencing for minority and at-risk populations in the United States. And how are you supporting minority researchers and institutions to do this work? Finally, let me just make a comment about the vaccination centers, the FEMA vaccination centers. I visited one, Madam Chair, earlier, last week actually, in Oakland, at the Oakland Coliseum. And I have to tell you, the coordination with FEMA and our healthcare providers, with the National Guard, with the county, it was remarkable. It's located in highly impacted, medically underserved communities. There was disability access. The people were treated with respect. They're trying to accomplish 6,000 vaccinations a day. And it was really one of the first times that I've seen such a wonderful operation taking place where people were treated with dignity and they were getting their vaccines. They had the 15-minute waiting area. And so I just want to thank all of those who are involved in that, because I believe this is a great model to use throughout the country. So thank you again.
Well, thank you so much for highlighting this really important area. And I'm thrilled that you could see the CVC. We're getting daily updates about the partnership. And I think the idea that people are treated with dignity and respect, frankly, that's a CDC value that's on our walls. So it was really nice to see it in action. What I can say is that this is the first emergency response where CDC has designated a chief health equity officer and has published and posted a health equity strategy for COVID. Our research is one key component of that equity strategy. It really starts with expanding the evidence base, and that is both funding and doing research that will answer some of these critical questions. The question about the genetic portfolio in terms of human genetic risk factors for severe disease, we'll need to get back to you on whether that's part of the issues that are being looked at. But I have to say that for our response, and certainly for Dr. Walensky, our commitment to health equity research is very, very high. And we look forward to your continued interest and to having good updates to provide you. Thank you.
Thank you very much. Thank you, Madam Chair.
Congresswoman Frankel.
Hello, thank you all again. I want to follow up on Congressman Lawrence's question. What's the latest on breastfeeding and COVID?
Good question.
You get the stump, the CDC panelists. We will, yeah, vaccine is fine to give with breastfeeding, but
well, what about can a mother transfer COVID to a
right. Okay. So my I don't want to give you the wrong answer. I know that we have this on our website. I'm pretty sure that we do not discourage breastfeeding in people who have recovered from COVID, and whether we're asking women who are actively infected to pump until they're out of that period. But I'm not aware of transmission through breast milk. But just caveat that with we'll get you a definitive answer.
Okay.
And congratulations on your grandchild.
Thank you. I told you I had a grandma question. So the other question I have, which has to do with monoclonal antibody treatment, does CDC recommend it?
The clinical recommendations for therapeutics are hosted by the NIH, and so they've been actively reviewing the literature and updating based on an expert panel that they have, like looking at the literature for how strongly is the evidence. The monoclonal antibodies are not all the same, and there are certainly some challenges with the variants because at least one of the monoclonal antibodies has some issues of benefit in the setting of variants. But the NIH website would be the most up to date in terms of that. We try to stick with vaccines and some areas that we're really concentrated on.
Okay, thank you. And you talked. I think you were talking before about some studies with school children and so forth. So I have another grandma question because I have a 2.5-year-old who has had no socialization with other children. Are there any studies for those little ones?
What I think you may have missed earlier was our real commitment to try to get kids back in school or children back in childcare because of that socialization.
Oh, okay, all right, I got it.
I also want to say we're in the process of updating our childcare guidance to make sure that those settings can be safe and also stimulating for the kids as appropriate. But we are doing a variety of surveys, sort of just-in-time surveys, to be tracking mental health and well-being in adults as well as children, including parents in terms of the special needs that parents have had during this really, really extraordinary period. And again, congratulations on your grandchild.
Well, I'm thrilled. Thank you. And Madam Chair, maybe when we get NIH in front of us again, I know that there have been some complaints where I live that again, in the distribution of the monoclonal antibody treatment, it's not in our underserved communities.
Okay, all right. No,
thank you, and I yield back.
Question, and maybe we can follow up before we get NIH before us, but we can ask that question. That's great. Thank you, Congresswoman Frankel. Congresswoman Bustos.
Thank you, Madam Chair. If you are okay with this, I'd like to get back to my Bureau of Prisons questions because we were so limited on our time. I'm going to give you some real life examples of what has happened where our office has run into these real scenarios during this pandemic. So we had an outbreak in our Thompson prison that was caused by the Bureau of Prisons transferring untested inmates from a different facility with a COVID outbreak, bringing those inmates into our facility in Thompson, Illinois. That's number one. Number two, we've seen instances where inmates with COVID-19 have been housed in the same cells with healthy inmates. Again, this is in Thompson, Illinois. My office had to demand that these prisoners be separated and isolated in order to deal with it. We had to intervene on that. Number three, we had other cases where the Bureau of Prison has not been using widespread testing to limit infection. And then last October, different prison, also in my congressional district in Pekin, Illinois, we had to call for testing of all staff and inmates. The request that came from our office followed an outbreak of at least 3 staff and 74 inmates. All right, so we made that request. So what ended up happening is they denied the request. All right, so we asked, took them a month to reply, they denied it. Then in December of last year, at the same prison, that number grows to 16 infected staff, 313 infected inmates positive with COVID-19. So we wrote Bureau of Prisons that same day asking them once again to test all staff and inmates in the prison. And once again, our request was denied. All right, so these are real life examples in our congressional district. These are just 2 prisons out of all of the prisons throughout the nation. So we see this as being out of control. They don't seem to make their staffing a prioritization. Again, I told you about a correctional officer who lost his life at the age of 42. So I get 2 questions. Do you know, is the CDC, are you guys aware that this kind of stuff is actually happening and we have these active cases right now? And then number 2, what do we need to do to fix this? Because we are bound and determined out of our office. We want to get this fixed.
Well, thank you for your question and your championing this issue. It's really important and it's really troubling, the descriptions that you provide. What I can say is that we have learned that the situation in prisons is extremely important to address. The usual pattern is there's disease in the community, a staff person brings it into the facility, and then the congregate setting makes people who are inmates very vulnerable for transmission that they can't really control. And so since the spring, where we did work very closely with some state and local health departments in investigation and response to outbreaks in prisons, really recommend testing of staff and infection control practices, very similar to what we've recommended in long-term care facilities, where again, the staff are in the community coming in and out, and the inmates or the patients in the long-term care facilities are really at the mercy of whatever the institution is doing. So what I can say is that we've been trying to update our guidance in light of the greater availability and better performance of the antigen testing for test results that you can quickly turn around and be continuously monitoring a population, usually the staff more frequently, and then a sample of others in the congregate setting. But I can commit that we'll go back and look and see to make sure that our information is getting out. I don't believe we have surveillance ourselves, but we are in close contact with the Bureau of Prisons as well as the state and local jurisdictions that usually respond to these concerns. Again, if you don't control things in the community, the congregate settings are of great vulnerability, but we've seen times where amplification in that prison setting then kicks off a much bigger community problem. So we're very interdependent, and we really rely on champions like yourself to put a spotlight on this important problem. So
yeah, I think an active response is very much necessary, and any oversight that you can provide, we'll continue that out of our office. But thank you very much, Doctor. With that, Madam Chair, I yield back. Thank you.
Thank you. Thank you. And I'm going to close in about in a moment here. This has been really a great roundtable, and the opportunity, which is that oftentimes we can't get the opportunity as a subcommittee, and whether it is in a caucus or a bipartisan large meeting, to really go back and forth with CDC. It's just so critically important to moving forward in this pandemic. Just quickly, what are we doing in a global response? I know we've rejoined the WHO. How are you partnering with the international efforts? This is we just can't combat this virus only in the U.S. So what are you doing about other regions of the country and the impoverished regions of the country, of the world? I'm sorry.
Yeah, thank you so much. Regardless of exactly when we can end the pandemic here in the U.S., it will not be over until the rest of the world is safe and well. As you know, global health is a strong commitment for CDC. We have staff in about 60 countries and activities And so we were very pleased to be able to rejoin the WHO in terms of the US government position. We're working, thanks to the resources that Congress provided, we have been able to fund activities in a number of countries to strengthen their ability to detect and respond to the virus, as well as to prepare for vaccination. And again, the interdependence of the global communities is very high with this. We know that the U.S. may be the hardest hit country right now, but there's a number of other countries where variants are circulating and are likely to be exported without our aggressive efforts. So our work is in those classic areas of infection control, surveillance, laboratory capacity, and rapid response, with the field epidemiology training program as sort of the signature of the workforce strengthening that we try to do overseas.
Okay. Dr. Messonnier, do you want to add anything to that, or we're going to wrap up here?
Just that I would echo Dr. Schuckett's point. In fact, I had the opportunity to participate with WHO yesterday in a convening about exactly these issues around vaccination. And our desire, of course, is to see every country be able to take advantage of these vaccines. If it's not controlled everywhere, then it's not controlled anywhere.
Mm-hmm. First, let me just say a thank you to both Dr. Schuckett, Dr. Messonnier, for this morning and this roundtable, and to Dr. Walensky. This is, it's so important for us, for this subcommittee, to hear directly from the CDC and to talk about the critical topics that are related to COVID, but where we do need to go. And I say that in just, if you're talking about a global response, and I'm asking all of you, please not to come to us with what we need to do with regard to a global response. We cannot afford to leave that behind. I just want to say is, and I think this is true of my colleagues, and I think on both sides of the aisle, and understand that you do have bipartisan support here in what the mission of the CDC has been, and what it is going forward. I just, my own expression of, I want to thank you for the truthfulness. We are making progress in some places. There are difficulties in others. We need to think about how we move forward in still others. But there is a reassurance and a sense of confidence in the scientific direction of where we need to go with regard to COVID. I'm not going to go backward. I want to go forward. We all do. But that reassurance and that confidence, I will be clear, and I'll speak for myself, that is not something that I have felt in the last several years. It was always about wondering whether or not there was accuracy and science at the root of what direction, activity, use of resources was all about. So I want to just say thank you. This committee is there to support your efforts. Congressman Cole asked you what the areas that we should move in. We want to do that alongside of you. I very simply thank you for telling us the truth. Thank you. It's the only way that we can move forward and to help bring this virus under some control. And we are champions for the CDC. Thanks for getting us back on track. And we're there to help you as we continue to do it. And with that, let me say a thank you to all my colleagues. The breadth of questions, their interest in wanting to get this under control is first and foremost in what they believe their responsibilities are. So with this, I will close the roundtable and look forward. I mentioned again that we are tomorrow talking about representatives with our public health partners, state and local level, to talk about public health infrastructure. Thank you all very, very much.